Good morning. I convene this hearing of the Subcommittee on Oversight and Investigations. Today we will be revisiting a subject that every member of this committee believes has gone on for far too long: the fraud, waste, and abuse rampant in our Medicare program. Last year, the Medicare program helped finance the medical services of approximately 51 million individuals, and in doing so, spent approximately $604 billion. Sadly, a budget that large makes the program a high target for fraud and abuse. Last year, the Centers for Medicare and Medicaid Services estimated that improper payments were almost $50 billion. Outside news reports have also pegged the amount lost to fraud as high as $60 billion. This is a shocking amount of taxpayer money to lose every year, especially considering that some experts tell us that we do not even know the full extent of the problem. These financial losses are simply unacceptable. To someone unfamiliar with the topic, some of the ways the government improperly pays out Medicare funding may seem completely unbelievable. For example, according to the Department of Health and Human Services Office of Inspector General, just a few years ago, the federal government managed to pay out $23 million in Medicare funding to dead people. One news story involved an Ohio doctor learning that he was the CEO of a medical practice only when a reporter called him to ask him about it, and the practice he was allegedly running, just a mailbox. Earlier this month, news broke out an accusation that one doctor in California was able to help facilitate approximately $22 million in inappropriate Medicare payments for wheelchairs. The economics of this also incentivize abusing the Medicare program as well. Last year, the Department of Justice issued a release noting that an individual was able to bill Medicare $6,000 for a wheelchair that costs $900 wholesale. These are but a few of the more darkly humorous examples, but this is no laughing matter. Quite frankly, it's a national outrage. It is not only the stories or amounts of money that should shock us all, but also the length of time the government has allowed this to continue. Since 1990, 24 years ago, the Government Accountability Office has designated the Medicare program as a high risk for fraud and abuse. A quarter century of wasted taxpayer dollars. When does it all stop? Think for a moment about a single company in the private sector that could lose this much money year after year. How could they still be in business today? We recognize that the administration is attempting to solve this problem. In the past few years, CMS has implemented new programs to provide enhanced screening for certain categories of providers. If a provider is servicing an area that typically is more susceptible to fraud, they may undergo additional scrutiny. I hope today to hear about how this is working and a number of fraudulent providers that have been stopped before they even entered the Medicare system. Meanwhile, the administration testified before the Committee on Ways and Means earlier this year on new collaborations with state governments on ways to combat fraudsters from moving their Medicare or Medicaid schemes from one state to another. I also hope to hear an update on this today. One of the main problems in the past with Medicare fraud was that those combating it often relied on a pay-and-chase model. That is, pay out claims from Medicare, learn of potential fraudulent activity, and then try to stop the fraud. Our government simply must do better. Today, I hope to hear about ways the administration is using new methods to use analytics to stop fraud before it happens. With the technological advances that the Medicare program has seen in this lifetime, it simply should be much more difficult for individuals to defraud the program. And one of the easiest ways to prevent fraud on the system and protect Medicare patients is by excluding the bad actors who have committed crimes in the past. That is, make sure there's pre-approved lists of providers. Yet news reports indicate that doctors who should not be billing Medicare continue to do so. Earlier this year, one news outlet reported that several doctors who had a lost medical license were still able to bill the Medicare program for millions of dollars. Committee staff has identified more problems as well, and at least 14 individuals convicted of FDA-related crimes. Health providers that have been debarred by the FDA do not appear to be excluded from the Medicare program. Worse, 6 doctors debarred from the FDA actually were paid over $1 million in Medicare payments in 2012. Finally, today I hope we hear about the steps that can be taken to further combat fraud. GAO has recommended some common-sense steps that would reduce fraud, such as removing Social Security numbers from Medicare cards, but CMS has yet to implement this recommendation. I want to thank the witnesses for joining us. And by the way, I also want to note that last night, HHS and CMS finally released their report to Congress on the second implementation of the fraud prevention system we're pleased we finally got this. We hope that these new technologies can yield even greater returns in the future. And I'm pleased with, I believe this is a committee that pushed for this, and we're pleased we finally got that. But unfortunately, it was last night, so haven't had a chance to review it fully. It is 9 months late, and if we're truly serious about combating Medicare fraud, we can't have these delays. But now I'd like to recognize the ranking member of this committee, Ms. DeGette, for 5 minutes.
Thank you very much, Mr. Chairman. This is the third hearing that the committee has had on Medicare fraud in the last 3 years, and I think it's perfectly appropriate to do that. Medicare fraud wastes money and endangers the care of seniors and the disabled. That's why I think we can work in a bipartisan way, and I'm pleased. We have witnesses today from CMS, the HHS Inspector General, and the GAO with us. I appreciate all of you joining us and look forward to hearing your perspective on where we stand and what we need to do to further reduce Medicare fraud, waste, and abuse. The administration has also made some important strides in this area. The Healthcare Fraud Prevention and Enforcement Action, or HEAT teams, a joint effort between HHS and DOJ, have played a critical role in these efforts. Medicare strike forces are a key component of HEAT, interagency teams of analysts, investigators, and prosecutors who can target emerging or migrating fraud schemes, including fraud by criminals masking as healthcare providers or suppliers. These efforts have produced immediate returns. In fiscal year 2012, the government recovered $4.2 billion in fraud, and from 2009 through 2012, it has returned a record-breaking $14.9 billion to taxpayers, more than doubling returns compared to the previous 4 years. CMS has also implemented many of the new tools provided to the agency under the Affordable Care Act. These new provisions of law have marked a dramatic shift in the way CMS fights fraud, moving from the old pay and chase model to the newer and much more effective approach of keeping fraudulent providers out of the Medicare system entirely. New Medicare providers are screened before they are allowed into the program. Providers in risky programs face additional scrutiny. CMS has embarked on an ambitious project to revalidate the enrollments of all existing 1.5 million Medicare providers and suppliers by 2015. This revalidation effort has deactivated or revoked almost 200,000 providers so far. The Affordable Care Act also limits the ability of fraudulent providers and suppliers to move from state to state or program to program by requiring all states to terminate providers whose billing privileges have been revoked by Medicare or have been terminated by another state Medicaid program for cause. And the administration has invested in predictive analytic tools that use algorithms and other sophisticated information technology to identify potentially fraudulent behavior. This technology has resulted in leads for more than 500 new fraud investigations and has provided new information for more than 500 existing investigations. Mr. Chairman, this is good news, but we also have some unfinished work for CMS that we're going to hear from the IG and GAO about. I'm particularly concerned about reports that Medicare Part C and D plans may not be doing enough to identify and report fraud. The private Part C and D providers are popular with many beneficiaries and have become a key and growing part of Medicare, and that's why we need to make sure that they're doing as much as traditional Medicare to fight fraud. And finally, Mr. Chairman, Congress needs to do our part, especially when it comes to financial support for the fraud fighters. Sequestration meant that the CMS program integrity funding declined in the last 2 years. And the majority staff's official hearing memo describes how funding cuts for the OIG will limit the agency's ability to carry out its mission, forcing staff reductions of over 200 people and forcing the IG to close over 2,000 investigative complaints and cut Medicare and Medicaid oversight by 20%. So at the same time, we're trying to increase a robust program of oversight. We're cutting the funding for investigations. Now, I think we can all agree this is penny wise and pound foolish. There's bipartisan agreement that we need to do more to wipe out Medicare fraud, and there's bipartisan agreement that every dollar spent to reduce fraud brings back more than a dollar in return. So we should fix this problem. I know a number of members on this and other committees have discussed bipartisan fraud prevention legislation. We should work diligently on that to give the CMS the tools they need to fight fraud, and we need to make sure that all of the fraud fighters have the funding they need to do this important work. And I yield back, Mr. Chairman.
Gentleman yields back, and now recognize the Chairman of the full committee, Mr. Upton, for 5 minutes.
Well, thank you, Mr. Chairman. I do share my colleagues' frustration on this issue for sure. It was 24 years ago when the GAO first announced the Medicare program was a big high risk for fraud and abuse. The program's financial sustainability has also been under threat for years. This committee has routinely, on a bipartisan basis, conducted oversight of the Medicare program in an effort to eliminate waste, fraud, and abuse. Our goal is to save taxpayer dollars and strengthen the program while rooting out waste, fraud, and abuse. Cannot alone keep the promise of Medicare. It is an important step that has the potential to benefit both seniors as well as taxpayers. To our witnesses here today, we've got a simple question. How can the government continue losing tens of billions of dollars, taxpayer dollars, every year? For years, the HHS has relied on a pay and chase model to recover Medicare losses, learning far too late that fraudsters routinely trick the federal government into paying them. But today there are some predictive methods that can help the government detect the fraud before the payments go out the door. I hope that that today's witnesses will do more to make these tools work. We should not pay potential fraudsters a dime, let alone the billions that we actually do. All taxpayers, those relying on Medicare, deserve better. Thank you for being here. I yield now to Dr. Burgess.
I thank the chairman for yielding and, too, want to welcome our witnesses. I appreciate your being here. Earlier this year, the CEO of a Texas hospital chain was indicted for defrauding the government of $18 million. The money continued to flow from the Center for Medicare and Medicaid Services, despite the hospital's long record of patient safety violations and billing fraud. Conditions at these facilities were bad. Patients died. In 2012, regulators moved to cut off funds. But a few months later, other officials at Center for Medicare and Medicaid Services provided well over $1 million to these hospitals. This case in Texas raises broader questions about CMS's ability to prevent improper payments to fraudulent or even dangerous providers. Providers that are excluded from one federal program because of improper or illegal conduct can often continue to be paid by other programs. It is my belief that providers that have been banned from federal programs for wrongdoing should be excluded from all federal programs, period. The incident in Texas prompted me to work with Chairman Upton and Mr. Barton. We sent a letter to CMS and the Office of Inspector General. We asked about the screening of providers receiving Medicare payments and other types of federal funds. Dr. Agrawal was kind enough to come into my office to brief me in response to these letters. They've been very helpful and informative, but you still can't help but be disappointed to learn that little progress has been made in this area over several decades. Numerous audits have been performed and recommendations have been made in ways to improve the system. Through the miracle of Google, you can find these recommendations going back well over 20 years. But 2 decades later, these recommendations continue to be ignored and taxpayers continue to lose money. The fact is that the Center for Medicare and Medicaid Services is not doing all they can to prevent this type of fraud and abuse of the system. You have the authority to implement tools to prevent abuse, yet you have not done so. We're here today to find out why. I look forward to hearing from our witnesses today and yield the balance of the time to the Vice Chair of the full committee, Ms. Blackburn.
Thank you, Dr. Burgess, and I want to welcome all of you. You have heard us talk about Medicare fraud, and we know that it is tens of billions of dollars, and it seems like it continues despite RAC audits and ZPICs and certs and the additional authorities that you all at CMS have been given. And we still have a permissive approach that allows providers with questionable backgrounds to continue to bill taxpayers. We've heard about doctors enrolled in Medicare who've been convicted of crimes. We have heard about companies that have been found guilty of fraud that are continuing to benefit. They rename themselves so they stay in the process. People are sick of this. And what we want to hear from you today is, what are you going to do about it? If you can't clean it up, let me tell you what, we're going to clean it up. But this is something that just absolutely has to stop. It is not your money. It is not the federal government money. It is the money of the taxpayer, and they are fed up with the inept attitudes and approaches that are coming out of some of these agencies. So we thank you for being here. We are concerned about the persistence of this issue, and we look forward to solving it. I yield back.
Gentleman yields back, and now recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Mr. Chairman, I appreciate your holding this hearing today. I care passionately about the Medicare program, and I want to make sure that we're doing everything we can to wipe out fraud. When I was chairman of this committee, we held hearings and passed legislation as part of the Affordable Care Act that gave CMS new authorities, new resources, and a whole new approach to reducing fraud. We're going to hear today about some of the successes of that new approach. We're also going to hear from members of the Congress outraged that there's any fraud. Well, it is outrageous to have any fraud, but it's also outrageous for members of Congress to say, which is outrageous, we're going to solve the problem, and then not hear a solution. We are seeing some progress. We've seen increases in enforcement, recovery for the taxpayers of that money that has been taken by fraud, and questionable providers have been kicked out of the program. CMS is using new predictive analytics to sniff out and take action against fraud. And I know that IG and GAO will tell us about the work that CMS still has left to do. And I expect the agency to take additional action to fully implement the Affordable Care Act's anti-fraud provisions and to address other concerns raised by the experts of these two agencies. I suppose one of the things the Republicans want to do to solve this problem is repeal the Affordable Care Act anti-fraud provisions, which they would have done in over 50 times they've tried to get the Congress to repeal the whole law, everything. We should be working in a bipartisan way in Congress to address anti-fraud funding shortfalls caused by the sequester and close gaps in Medicare law identified by the administration and by GAO and by the IG. There's no reason we can't work together on these issues unless we just want to use them for talking points in an election year or the year before the next election. But, Mr. Chairman, we need to address Medicare waste, fraud, and abuse. We need to look at all three of these areas. And probably the biggest source of waste of taxpayer funds in Medicare are the high prices that Medicare Part D plans pay for prescription drugs. Mr. Chairman, last week I wrote a letter to you and Chairman Upton requesting that the committee hold a hearing on the implications of the high cost on the Medicare Part D program of Sovaldi, the new hepatitis C drug manufactured by Gilead Pharmaceuticals. And I hope we hold this hearing. Sovaldi has been hailed as a breakthrough treatment for individuals suffering from hepatitis C, but it's costly. $1,000 per pill, or $84,000 for the entire 12-week course of treatment. And there are an estimated 350,000 Medicare Part D beneficiaries with hepatitis C. As a result, a recent analysis was done by researchers from Georgetown University and Kaiser Family Foundation that said Medicare Part D will be spending $6.5 billion, or 8%, in 2015 for this one drug. Mr. Chairman, this problem is exacerbated by the fact that Medicare Part D plans are not able to effectively negotiate for lower prices for Sovaldi or any other drug, while Gilead provides substantial discounts on the drug in other countries. And for the VA and the Medicaid program, these discounts are not available to Medicare Part D plans. The result of this inability of Medicare Part D plans to negotiate for lower drug prices is the waste of hundreds of billions of taxpayers' dollars. this is a problem we should solve, at least examine. I hope this committee will hold a hearing, but I've written a lot of letters asking for hearings, and if it affects the fossil fuel industry, forget about it. If it affects the pharmaceutical industry, well, they're big campaign contributors. But we ought to look into this issue. We could save money, and we could be doing the Medicare program a great service, and we could be doing people who need this drug a great service. At least we ought to look at the problem. Today's hearing on reducing Medicare fraud is useful. Let's approach it in a constructive manner. I thank the witnesses for being here today, and I yield back the balance of my time.
The gentleman yields back. And I'd like to introduce the witnesses on the panel for today's hearing. Dr. Shantanu Agrawal, did I say that correctly? Thank you. The Deputy Administrator and Director of the Center for Program Integrity at the Centers for Medicare and Medicaid Services. Mr. Gary Cantrell is the Deputy Inspector General for Investigations of the Office of Inspector General at the Department of Health and Human Services. Today, Mr. Cantrell is accompanied by Ms. Gloria Jarman. She is the Deputy Inspector General for Audit Services in the Office of Inspector General at the Department of Health and Human Services. And Ms. Kathleen King is the Director of Health Care at the U.S. Government Accountability Office. I'll now swear in the witnesses. You are aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have any objections to testifying under oath? None of the witnesses have indicated that, so the chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you desire to be advised by counsel during your testimony today? All the witnesses decline that, so in that case, would you all please rise and raise your right hand, and I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. And all of the witnesses said yes. So you are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. I'll ask all of you to give a five-minute opening statement summary. Dr. Agrawal, will begin with you.
Thank you. Chairman Murphy, Ranking Member DeGette, and members of the committee and subcommittee. Thank you for the invitation to discuss the Centers for Medicare and Medicaid Services program integrity efforts. Enhancing program integrity is a top priority for the administration and an agency-wide effort at CMS. We share your commitment to protecting beneficiaries and ensuring taxpayer dollars are spent on legitimate items and services. I would like to make three major points in my oral remarks this morning. First, our work in implementing new provider enrollment and screening standards at CMS has had significant tangible program integrity impact and moved us firmly towards prevention on these issues. Second, we recognize that further work remains to improve our safeguards, and we are taking specific proactive steps toward those improvements. And finally, one of our many tools is our advanced predictive analytics system, the fraud prevention system, which has continued to develop and deliver a positive return on investment in just its second year of operation. That ROI has been certified by the Office of Inspector General. Thanks in part to the authorities and resources provided by the Affordable Care Act and the Small Business Jobs Act of 2010, CMS is changing the program integrity paradigm towards a focus on prevention to identify and combat waste, abuse, and fraud in our system. Our enhanced screening requires certain categories of providers and suppliers that have historically posed a higher risk of fraud to undergo greater scrutiny prior to their enrollment in Medicare. The Affordable Care Act also required CMS to revalidate all existing 1.5 million Medicare suppliers and providers under the new screening requirements. We have real, tangible results from these efforts to share. Since March 2011, more than 930,000 providers and suppliers have been subject to these new screening and validation requirements. Over 350,000 providers and suppliers have had their billing privileges deactivated as a result of revalidation and other screening efforts, and over 20,000 providers and suppliers have had their billing privileges entirely revoked. Just since the start of this year, CMS has revoked over 800 providers for lack of appropriate licensure. These deactivations and revocations mean these providers can no longer bill or be paid by Medicare. Our experiences with provider screening tell us that there is more work to be done to continue to enhance the screening process. We already rely on over 200 databases in our current screening processes, but challenges remain. For example, CMS has historically relied on Medicare exclusion and GSA debarment data to identify relevant felony convictions because there is not a centralized or automated means of obtaining felony conviction data. Using these databases on an automated basis, CMS ensures that individuals convicted of healthcare fraud related crimes, or other conduct that bars them from contracting with the federal government are denied enrollment to Medicare or swiftly removed from the program as part of our routine screening and validation. However, to address the lack of an off-the-shelf solution for all criminal data, CMS is developing a process to match enrollment data against numerous public and private data sources to ensure receipt of timely conviction data. Additionally, in April 2014, CMS announced that high-risk providers will now be subject to fingerprint-based background checks to gain or maintain billing privileges for Medicare. We are also applying our enrollment and screening processes more broadly. Just a few weeks ago, CMS issued a final rule to extend enrollment requirements to Part D, which prevents revoked or excluded providers from prescribing to Medicare beneficiaries. The same rule also allows us to use data from the Drug Enforcement Agency to ensure prescribers are appropriately licensed to prescribe certain drugs and enables CMS to remove them from Medicare when the DEA has taken an action against an individual's license. In addition to enhanced provider screening procedures, CMS is using private sector tools and best practices to stop improper payments of all types. Since June 2012, the fraud prevention system has applied advanced analytics on all Medicare fee-for-service claims on a streaming national basis. In its second year of operations and through over 70 active models in the system, FPS identified or prevented more than $210 million in improper Medicare payments, double the previous year, and resulted in CMS taking action against 938 providers and suppliers. The tool is part of CMS's comprehensive program integrity strategy. For example, the FPS is used as part of an agency focus on home health services in South Florida, which includes our screening processes, implementation of an enrollment moratorium, on-the-ground investigations, and collaboration with law enforcement. CMS is expanding the use of FPS beyond the initial focus on identifying potential fraud into the areas of waste and abuse, which we expect to increase future savings. While we have made significant progress to address areas of vulnerability, we also know that more work remains to further refine our efforts and prevent improper payments and fraud in the first place. I look forward to answering the subcommittee's questions on how we can improve our commitment to protecting taxpayer and trust fund dollars, while also protecting, and I think very importantly, beneficiaries' access to safe, high-quality care. Thank you.
Thank you. Mr. Cantrell, you have 5 minutes.
Good morning, Mr. Chairman and other distinguished members of the committee. I am Gary Cantrell, Deputy IG for Investigations, and I'm joined today by my colleague, Gloria Jarman, who's Deputy IG for Audit Services. Thank you for the opportunity to testify about OIG's efforts to fight fraud, waste, and abuse in Medicare and Medicaid. OIG utilizes a range of tools in this fight, including audits, evaluations, investigations, enforcement authorities, and educational outreach. We focus our resources on areas most vulnerable to fraud, so we attain the greatest impact from our work. OIG works closely with the Department of Justice, CMS, and other federal and state law enforcement partners to bring those who commit fraud against our programs to justice. Our Medicare Fraud Strike Force teams, located in 9 cities throughout the country, exemplify this approach. The OIG and our partners are committed to fighting and preventing fraud, waste, and abuse. Our efforts have produced impressive results. In 2013, our work resulted in record numbers of criminal convictions and civil actions, and over the last 5 years, we have recovered more than $19 billion from those defrauding federal health care programs. And our return on investment is over $8 for every dollar spent. Perhaps even more important, we're seeing strong indicators of a deterrent effect. When we work together to shed light on program vulnerabilities, put criminals behind bars, and CMS takes appropriate administrative actions, our efforts are most successful. We have seen significant declines in Medicare payments across several program areas in strike force cities where we've focused our efforts. For example, following federal enforcement and oversight activities, there have been sustained declines in Medicare payments for DME, home health, ambulance, and community mental health centers, or CMHCs. Nationwide, Medicare payments for CMHCs have decreased by approximately $250 million annually. Total Medicare payments for ambulance services in Houston are down approximately 50%. Miami area DME payments have decreased by approximately $100 million annually since the launch of the strike force. And since 2010, home health payments have decreased nationally more than $1 billion annually. Despite these successes, more needs to be done. Fraud schemes are constantly evolving and migrating, And some of OIG's top oversight priorities include the rise in prescription drug fraud and schemes involving home-based services. Rarely are these schemes perpetrated by one provider operating independently. There's often a network of individuals, including business owners, patient recruiters, healthcare practitioners, and sometimes even the patients. Kickbacks in the form of cash or drugs bind these networks together. The federal forfeiture are a valuable tool to help defund and disrupt illegal activities and can serve as a powerful deterrent. Empowering OIG to execute forfeiture warrants would help curb the profitability of healthcare fraud and exert a deterrent effect. Removing Social Security numbers from Medicare cards could also protect patient data and disrupt fraud schemes. The theft of patient and provider data underpins many of our cases. And in a recent case, criminals perpetrated a $100 million fraud scheme by stealing the identities of doctors and thousands of patients. In conclusion, I must note that OIG's mission is challenged by declining resources at a time when our oversight responsibilities are growing. OIG is responsible for oversight of about 25 cents of every federal dollar. However, since 2012, we've lost 200 employees and expect to reduce our Medicare and Medicaid oversight by 20% by the end of the fiscal year. Now is not the time to reduce oversight in the face of a growing and changing program, and OIG is a proven investment. We would appreciate the committee's support in securing full funding of OIG's 2015 budget request. And thank you for the interest and the opportunity to testify. We would be happy to answer any questions.
Thank you. Ms. Jarman, I don't think you have a statement, do you? No, Ms. King, you have a statement? Thank you. You recognize for 5 minutes.
I do. Chairman Murphy, Ranking Member DeGette, and members of the subcommittee, thank you for inviting me to talk about our work regarding Medicare fraud, waste, and abuse. CMS has made progress in implementing several recommendations we identified through our work to help protect Medicare from fraud and improper payments, but there are additional actions they should take. I want to focus my remarks today on 3 areas: provider enrollment, pre- and post-payment claims review, and addressing vulnerabilities to fraud. With respect to provider enrollment, CMS has implemented provisions of the Patient Protection and Affordable Care Act to strengthen the enrollment process so that potentially fraudulent providers are prevented from enrolling in Medicare and higher risk providers undergo more scrutiny before being permitted to enroll. CMS has recently imposed moratoria on the enrollment of certain types of providers in fraud hotspots and has contracted for fingerprint-based background checks for high-risk providers. These are positive steps. However, CMS has not completed certain actions authorized in PPACA, which would also be helpful in fighting fraud. It has not yet published regulations to require additional disclosures of information regarding actions taken against providers, such as payment suspensions. And it has not published regulations establishing the core elements of compliance programs or requirements for surety bonds for certain types of at-risk providers, including home health agencies. With respect to review of claims for payment, Medicare uses prepayment review to deny payment for claims that should not be paid, and post-payment review to recover improperly paid claims. Prepayment reviews are typically automated edits in claims processing systems that can prevent payment of improper claims. Post-payment reviews are those that are made after the fact and recover payments. We have found some weaknesses in the use of prepayment edits and have made a number of recommendations to CMS to promote the implementation of effective edits regarding national policies and to encourage more widespread use of local prepayment edits by Medicare administrative contractors. With respect to post-payment claims review, we recently completed work that recommended greater consistency in the requirements under which 4 post-payment review contractors operate, when it can be done without reducing the efforts to reduce improper payments. CMS agreed with our recommendations and is taking steps to implement them. We also recommended to CMS that they collect and evaluate how quickly one type of post-payment review contractor, the Zone Program Integrity Contractors, or ZPICs, takes action against suspect providers. CMS did not comment on this recommendation. We also have further work underway on the post-payment review contractors to examine whether CMS has strategies to coordinate their work and whether these contractors comply with CMS's requirements regarding communications with providers. With respect to vulnerabilities to fraud, we have made recommendations to CMS over the last several years, and CMS has implemented several of them, including establishing a single vulnerability tracking process and requiring the MACs to report to them on how they have addressed vulnerabilities. However, CMS has not taken action to address our recommendations to remove Social Security numbers from Medicare cards, because display of these numbers increases beneficiaries' vulnerability to identity theft. We continue to believe that CMS should act on our recommendations, and we are currently studying the use of electronic card technologies, such as smart cards for Medicare cards, including potential benefits and limitations and barriers to implementation. Because Medicare is such a large and complex program, it is vulnerable to fraud and abuse. Constant vigilance is required to prevent, detect, and deter fraud so that Medicare can continue to meet the needs of its beneficiaries. I'd be happy to answer questions. Thank you.
Thank you. I thank all the witnesses. I'll now begin some questions for 5 minutes. Dr. Agarwal, you need to know whether the agency's actions have been successful in reducing fraud and abuse. And one way that the agencies examine the effectiveness is by measuring performance as required by the Government Performance and Results Act of 1993 as amended by the GIPR Modernization Act. One of CMS's goals is to fight fraud and work to eliminate improper payments. Isn't that right?
We are absolutely focused on the improper payment rate and working to reduce that rate.
And isn't it correct that CMS target improper payment rate for Medicare fee-for-service for fiscal year 2013 was 8.3%? Was that about what the target was?
Yes.
Now that translates to about $36 billion in losses. So what I don't understand is why is it acceptable to have about a $36 billion loss rate that's acceptable?
I don't think it's about acceptability, sir. We are focused on the improper payment rate and reducing that rate as much as feasible. I will say just 2 points on the improper payment rate. One is it is not equivalent to the fraud rate. Improper payments do not measure the amount of criminal behavior that is in the Medicare program. That's often an area of confusion I find amongst stakeholders. Second, what it really does, I think, demonstrate is the ability of providers to follow our strict payment guidelines and requirements, namely, and most particularly, documentation requirements. So we see, for example, areas where the improper payment rate continues to rise, like certain institutional providers, DME suppliers, home health services.
And it went up for 2013 for you to 10.7%, I think.
Well, I think what we've done is institute a lot more specific requirements in those areas in order to reduce fraud, waste, and abuse. Those requirements can take time for providers to catch up with, and what we see is documentation lags and the improper payment rate goes up.
I guess what I'm concerned about that you went from 8.5% to 10.7%, which says it's getting worse.
Again, I think it is an outcome of our more stringent requirements. I think this shows the balancing act between trying to be very strong on program integrity, which is really enforced by strong rules and regulations, and then those rules and regulations being difficult for providers to follow. The
bottom line up front is you didn't meet your goals and it's getting worse.
Correct. Well, we did not meet our goal, and we have taken proactive steps to help reverse that trend. One is we work very closely with providers to help educate them on our rules, to make sure that they're able to follow our rules, follow our documentation requirements. We've instituted, sort of point audits that allow us to look at specific.
I get all that. I'm just saying bottom line for taxpayers is the amount of money that's been done in improper payments is greater than the entire budget of the state of Pennsylvania. So I hope you'll improve that. Let me ask this. I'm trying to find ways that can facilitate you on this, because you're probably familiar with that old quote from the bank robber Willie Sutton of why he robbed banks, and he says, because that's where the money is. So with the $600 billion in Medicare spending, that looks like a ripe target for a lot of people. So the fact that he was convicted as a bank robber, I believe the way the laws and regulations are written right now is those kind of criminal convictions wouldn't prevent you from giving someone Medicare payments. Am I correct? They could still slip through the system?
Certain convictions we can revoke from the Medicare program for.
Would bank robbery be one of them?
Felony convictions, so I'm no lawyer, I assume bank robbery is a felony conviction. If it's a felony conviction, then yes, we can kick people out of the Medicare program.
I just want to be sure, Mr. Cantrell, would you know if someone with some felony conviction? We're trying to improve this, so I'm thinking if it's not there, I would like to know. Insurance fraud, auto insurance fraud, tax fraud. I believe tax fraud is still acceptable, that they wouldn't be kicked out of the program. Do either of you know that?
As it relates to our exclusion authority,
yes,
there are requirements that link it to in connection with the delivery of health care item or service.
But if it's not health care, so if someone was involved with auto insurance fraud or assault or convicted of clinical research fraud, if it's not health, right, they can still be a Medicare provider. Am I correct? The way the law is currently written.
We have very prescribed guidelines for what we can revoke for. They are 4 types of felony
I'm trying to help you.
convictions. These
So
are not.
If you would like it stricter, we need to know this. So if someone has a history of criminal fraud, criminal felony behavior, and you can't exclude them, I think one of the best predictors of future problems is past. And if someone has a pattern of this, can they still slip through and be a provider for Medicare?
Yeah, I think the agency agrees with you, sir. In fact, we've taken steps in the last year to put out a proposed rule that would actually expand our use of this felony conviction.
Well, we'd like to work with you on that. Let me ask one other thing. Can someone with a foreign address or just a box number also be a Medicare provider? Do you go through and check those records?
We do check records. We have automated checks for addresses, as well as the ability to conduct on-site visits to make sure that these are legitimate places of service.
Can someone with a foreign address be a Medicare provider?
I'd have to check, I think, specifically on that, but I believe the answer is no.
Okay, we'll find out. Ms. DeGette, you're recognized for 5 minutes.
Dr. Agrawal, in your testimony, you discussed how taxpayers get a significant return on investments to reduce Medicare fraud. Is that right?
Yes.
And I've been told for each dollar we spend, we save more than $1. Is that right?
Yes.
Why is that true?
Our activities are having impact. I think we
But
clearly...
why for each dollar that we spend do we save more than $1?
I think our activities have a cumulative effect, so they can actually prevent dollars from going out the door in the first place. They have sentinel effects where we see impact beyond just the specific providers and suppliers that we're looking at. I think all those things cumulatively lead to that higher ROI.
It's a systemic issue.
Correct.
Okay. And what are the sources of funds for CMS program integrity efforts?
We have a variety of funds. We have both Medicare and Medicaid funds. We have Small Business Jobs Act funds that are connected, for example, to the FPS, HCFAC funds.
How much will CMS spend this year on Medicare and Medicaid program integrity efforts?
I'd have to come back to you with a specific number. I'm not
I'd
sure
appreciate
about
it if
the
you'd
total
supplement
aggregation.
your response.
Absolutely.
Do you remember how much you spent in 2012?
No, ma'am.
Okay. Do you know if there's been an increase or a reduction in funding for fighting fraud over the last 2 years?
What we have experienced between the sequester and then sort of flat funding is a general flattening out of our funding, and that has forced us to make certain budgetary decisions about what programs and tools to focus on.
Now, you mentioned the layoffs, and I talked about that in my opening statement. What other programmatic adjustments have you made?
Well, I might just point out that the layoffs most significantly impacted the Office of Inspector General, which we take seriously.
So, Mr. Cantrell, maybe you can answer that.
Sure. Our budget is primarily funded, our healthcare oversight is primarily funded by the Healthcare Fraud and Abuse Control Act. And that fund we get about $300 million a year. But with sequestration, it takes about $14 million out of that healthcare oversight fund. We have another funding stream we call our discretionary fund that funds all of our other activity related to the Department of Health and Human Services, but not the Medicare and Medicaid program.
Have you made programmatic adjustments to account for the budget cuts? Or have you just laid people off?
We haven't laid people off. We've lost people through attrition.
Okay.
We've reduced investments in things like training equipment.
But you have fewer people doing the job, right?
That's correct.
So are you trying to make them figure out how to do the job more efficiently?
We do. We're trying to focus our work on areas where we can have the greatest impact. So the biggest thing we're doing is picking our work. There's much more work in this program than we have the ability to do. So we're being very strategic about the work that we select and placing our resources in areas where they can have the greatest impact is our strategy here.
So this is really a situation, if we adequately funded you, then you could actually do more investigations and pick more cases, correct?
Absolutely.
Now, for either one of you who knows the answer to this, while we've been having a slight reduction in the funding, at the same time, the Medicare population has increased and Medicare expenditures have increased. Is that correct, Dr. Agrawal?
That is correct.
You know, Mr. Chairman, I think that there are some things you can do by efficiencies and by being smart and so on. But when you cut $30 million from CMS integrity efforts, I'm not sure how much you can make up for that. Dr. Agrawal, the administration has asked for a significant increase in program integrity funding for fiscal year 2015, over $400 million. Is that correct?
Yes.
And what would you do with that funding?
That funding would really allow us to expand programs that we know have impact. As an example, our prior authorization demo could be expanded nationally into program areas that it doesn't currently cover. We know that that could have impact.
Do you think that would assist you?
Absolutely.
Perhaps you can also add to your supplement, to your testimony, some of the things, some of your plans for this money if Congress appropriates the money.
I'll do that.
Okay, thanks. Mr. Cantrell, let's see. What would you be able to do with the funding if we adequately funded your agency?
Well, first we would hire more investigators, auditors, evaluators, attorneys to support the work that we're doing and actually have more boots on the ground performing this type of oversight work. We also need investments in technology as we deploy electronic health record systems throughout the country, and that becomes a greater adoption of EHR. That creates digital evidence that we have to collect, store, maintain, and sort through. So we need investments in technology to maintain, to kind of stay above water here in this area that continues to evolve.
Thank you. Thank you, Mr. Chairman. I yield back.
Thank you. Now recognize Mr. Burgess, or Dr. Burgess, for 5 minutes.
Thank you, Mr. Chairman. So again, I appreciate everyone being here this morning. If I understood your testimony correct, we're doing a great job. If you just give us a little bit more money, we'll do a better job. And yet the problem continues. And year after year after year, we're here having these same hearings. Let me just ask, I feel I've got questions that I must ask, but at the same time, I feel obligated to make the statement that, yes, I supported the sequester. It was policy that I supported, but it was the president who signed it into law. Now, we all knew after the president signed it into law that it was going to affect the Department of Health and Human Services significantly at a time when the president's health care law was being implemented. So I had asked repeatedly for someone, the Secretary of HHS, to come to this committee and talk about how you were going to deal with an 8 to 10% reduction in across-the-board funding. How are you going to prioritize? I would think, Mr. Cantrell, you would prioritize your department. I don't know why you would prioritize money going to build an exchange that you then had to reinvest when they didn't build the exchange the right way. But I'm not the head of HHS, so I don't make those decisions. So please forgive me if I am a little bit circumspect about people coming in here and saying more money for my agency, more money for my agency, when, my God, you have wasted so much money in that agency in the last 4 years. It is just absolutely astounding. Now, let's get to the reason why we are here. Mr. Cantrell, do you have recommendations, your office, the Office of Inspector General, have recommendations, and have you made recommendations to the Center for Medicare and Medicaid Services relating to improvements in the screening of providers that have not been adopted?
I can answer that question. We have several recommendations. In fact, we posted in March 2014 a compendium of priority recommendations that are unimplemented, and that has over 100 recommendations to CMS, many related to Medicare and Medicaid payment and process issues, and some related to quality of care. So we do have several recommendations that we have been working with CMS, and they have been unimplemented. But
Well, let
we're
me just
still
ask
working with them.
the question, Dr. Agwal or Mr. Cantrell, what is the status of the implementations of those recommendations from the Office of Inspector General?
You know, we have appreciated the recommendations that are provided to us both by the OIG as well as GAO. We work diligently to implement those recommendations based on our, ability to do so, budgetary and other resource constraints. Since January 2013, we've completed or closed out over 60 recommendations provided to us by GAO and OIG. We continue to work through the remaining recommendations in order of priority based on their potential impact on our program. But we do appreciate those recommendations.
Will you provide to the committee a list of those recommendations that have been made which have not yet been implemented? Are you able to do that?
I can do that.
And the committee would appreciate that information. There was an article in Bloomberg not too terribly long ago talking about individuals who doctors had lost their licenses and continue to get paid by Medicare. I mean, I always lived in fear. As a practicing physician, I always lived in fear of getting a bad mark at the National Practitioner Data Bank. I would assume that all of these doctors have recorded activity in the National Practitioner Data Bank. So, Dr. Agrawal, do you query the National Practitioner Data Bank when you authorize or when you permit someone to bill the Medicare system?
Yes, so I share your feelings about my medical license as well, Dr. Burgess. It's something that I guard very carefully and want to make sure is untarnished. We access a lot of different data sources, including the NPDB and over 200 other data sources to check things like licensure. As I said in my opening remarks, we revoked over 800 providers just since the beginning of this year for licensure issues. This was an area of vulnerability for us. Even a couple of years ago that we have really worked hard to close by getting access to all the right data at the state level so that we can do automated checks on licenses literally every week and get and revoke any providers that don't have appropriate licensure.
You know, a lot of the substance of this hearing came about because of a local article in a newspaper back home where you had a doctor, a CEO of a hospital chain, who had received $17 million from the stimulus to improve medical records in his system. And then it was found that the medical records were boxed up and sitting in the basement being eaten by rodents. So I guess you would classify that as meaningless use of health information technology. But yet at the same time, with this bad and egregious an offense, he continues to get paid by CMS. Is this just a one-off, or are there other such stories out there in the country?
I think it's a notable case. It's one that I know well personally. I can tell you that we have a lot of checks in place to ensure that that kind of thing does not happen both before payments are made and after.
But it did happen.
I agree that it did. I think in part, this person was providing misleading information to the agency, and we were also made aware by, about law enforcement concerns well into their process. I think OIG would agree here that early collaboration between our agencies is very helpful. That allows us to take the actions that we can take very quickly, and we can work with law enforcement to facilitate their actions as well.
Then do it.
Thank you.
Early collaboration is the key. I yield back, Mr. Chairman.
Just a quick question. When you're getting that clarifying data for the committee with regard to recommendations you made that have not been implemented, if they have not been implemented, could you let us, with each one, explain some reason of why that is, if it's some federal action, if there's any state action, if states are not sending you data? That's extremely important. We want to help you, but we need to have that thorough report. Now recognize the gentleman from Texas, Mr. Green, for 5 minutes.
Thank you, Mr. Chairman and Ranking Member. Dr. Agwa, can you tell me more about how the Affordable Care Act helps CMS and fight Medicare fraud? Specifically, can you expand a little on CMS's provider enrollment and screening process?
Absolutely, and thank you for the question. The Affordable Care Act has had significant impact on our ability to safeguard the program, and particularly in the area of provider enrollment and screening. Without the ACA really required us to, for the first time, categorize providers based on the risk of fraud and subject higher risk providers to greater levels of scrutiny. That includes automated checks, site visits, fingerprinting. All of that was made possible by the Affordable Care Act. In addition, our moratorium authority, our requirement to revalidate all providers on a cyclic basis, again, comes out of the ACA.
Okay. I appreciate it because some of the savings from the ACA was actually giving CMS the tools to do to go after the fraud that we would prefer not to read it on the front page of the papers before we can get to you. The health reform bill includes new authority for CMS to enact moratoria on enrolling new providers. Has CMS used this new tool yet?
We have. So we implemented the first moratoria last summer in July. We now have a total of, we have moratoria in 2 different provider categories, ambulance services and home health services in 7 different metropolitan areas, and are closely monitoring the impact of that moratorium. I should also say, while the moratorium is in place, we have really stepped up our activities to make sure that we're taking action on the providers that are already in the moratoria area.
Okay, good, because I represent the Houston area, and it seems like we're ground zero for some of the fraud, and I appreciate that. How does the moratoria help fight the fraud?
Well, what the moratoria really allows us to do is essentially close the door for enrollment, in this case for new ambulance services as in Houston or home health agencies in other parts of the country. That gives us an opportunity to clean up the providers or suppliers that are already there and work very closely with law enforcement. We actually work very closely with them in identifying these areas for the moratoria and then in the stepped-up activities to make sure that we're cleaning up those areas before eliminating the moratoria.
Okay. The Affordable Care Act required Medicare providers to report and return overpayments once they're identified. Failing to do so would constitute a federal crime under the False Claims Act. Was this requirement necessary, and have you seen evidence that providers are complying with this requirement, and is it being enforced?
I'm sorry, Congressman, I missed the beginning part of your question.
The Affordable Care Act required Medicare providers to report and return overpayments once they're identified, and failing to return those payments would constitute federal crime under False Claims Act. I was wondering if this is being enforced and how it's working.
Yes, we are looking we published a proposed rule on this, and we're looking to finalize that. We do see providers actually taking just the statutory authority seriously itself and actually returning overpayments voluntarily. We have also promulgated another proposed rule that would actually have overpayments follow providers. If they tried to close down one location and open up another one, they'll have to pay the overpayment before they can get into the program again.
Okay. Ms. King, do you have a view on how CMS is doing at implementing the broad range of new Affordable Care Act anti-fraud positions? And after you, I'd like to give Dr. Aguilar a chance to respond.
Yeah, we view the new provisions in the Affordable Care Act as a positive step because we're in favor of keeping people out of the program who shouldn't be in the program. And right now, our investigative team has work underway to determine whether people are being kept out of the program as they should be and whether people who have committed bad acts and should be thrown out of the program are being thrown out. And we should be able to report on that by the end of the year.
Okay, thank you. Dr. Aguilar, do you have a comment on that, how CMS is doing with the GAO?
Sure, and again, I appreciate Ms. King's comments and agree that their recommendations are very important. We've done a lot based on their recommendations to strengthen our program in Part D, in basic provider enrollment and screening. There's other recommendations that we continue to work through, but they are very helpful to us.
Okay, thank you, Mr. Chairman. I yield back.
Thank you. Now recognize Ms. Blackburn for 5 minutes.
Thank you, Mr. Chairman. Dr. Agrawal, I want to come to you. You mentioned in your testimony that since 2011, 20,000 providers and suppliers had their participation in Medicare revoked, and some from felony convictions and some from administrative actions. And also, you mentioned that CMS has issued a proposed rule that would clarify the list of felony convictions that may result in a denial of participation. And yet, I've heard from constituents that some of these bad actors that are out there continue to do business because they change their names and they start a new business. But it's the same bad group of people. And we have seen this time and again, and I know the chairman a couple of years ago had a piece of legislation that went through judiciary, didn't get very far at the time. We need to bring it back. It would say if you've ever been convicted, you can in no way participate and benefit. GAO has recommended that CMS could potentially thwart this type of behavior by strengthening enrollment procedures as is currently authorized. And CMS could require additional disclosure information on the front end, and yet according to GAO, it hasn't been done. My question to you is this: after 20 years of being on the fraud high-risk list, when can the taxpayers expect to see results from some common sense activity in this arena?
Well, I think we clearly are seeing results, and I think you saw that in the testimony that I provided to the committee this morning, that there are clear results of our activities. Now, I too am frustrated by the kind of case that you're identifying. If there are cases like that, specific ones that we can work on with your office, I'd be happy to do that. Let me just say that we are working towards strengthening disclosure requirements. We actually have a proposed rule that would require far more disclosure to resolve issues just like that, so that we can actually prevent people from entering the program that are just, changing names and switching from company to company. I think that kind of approach is indeed very frustrating, and we are working to expand our authorities to get greater clarity.
Well, you're not giving me the granular level that I'm seeking. Tell me specifically what you're going to do, because when I talk to my constituents, they say, we want to know specifically what is going to be done about this. It is our money and you're wasting it.
Well, beyond the overall approach that I've described, there are two things that I think will affect this situation. One is we are expanding our ability to actually revoke or deny enrollment for a broader list of felony convictions than we currently are authorized to do. And second, we are requiring greater transparency at the time of attempted enrollment, so that if there are overpayments from other enrollments that provider had, we can actually deny enrollment until those overpayments are recovered. Those are two very specific things that I think will go directly at the cases that you're talking about.
But why don't we let them in the program in the first place?
Well, again, historically, I think Medicare has had a more open enrollment process than it's had since the passage of the Affordable Care Act. So we are working very diligently every day to clean up those records, and hence the numbers that you've seen of over 300,000 deactivations and over 20,000 revocations.
Okay, does CMS give bonuses?
Pardon me?
Does CMS give performance bonuses to employees?
I'm not sure. I don't really manage our HR function. I don't know what kind of bonuses that we do.
You get a performance bonus?
I joined the agency in this role 3.5 months ago. I haven't qualified for a bonus
Mr. Cantrell, did you get a performance bonus?
We do pay performance bonuses in OIG based on our rating of record.
Okay. Ms. Jarman, HHS, do they do performance bonuses?
I'm in the same office with Mr. Cantrell. There are performance bonuses based on performance.
All right. Let me come back, Mr. Cantrell, and then also let me talk to you about this issue. I've got a prop back here. Identity theft and privacy is a huge issue, and this is something we've tried repeatedly to get cleaned up. This is a copy of a Medicare card. Now, what we have that's a problem with identity theft, you've got the program, the health insurance program is in Medicare, you've got the name, and this Medicare claim number is the Social Security number. When are you going to de-link these and make certain that a Social Security number and a name do not appear on this card? When are you going to change that?
I think you're probably asking me, not Mr. Cantrell. So we have.
I'm sorry, I thought I called for you. And then I would like to know from Ms. King, has GAO recommended doing this?
We have.
Okay. Back to you, Doctor.
So this is an area that we've looked at. We've appreciated the recommendations. We are not, as an agency, opposed to the idea. It is, however, a challenging idea that requires a lot of sort of rigor to implement.
Do something. Take an action.
I
be
think
brave.
we need to be
yell back.
adequately resourced by the Congress to be able to do that. But yes, we appreciate the ability.
Well, Dr. Agua, do you have the authority to make that decision to eliminate the Social Security number from the cards?
I think we as an agency could do that. Again, however, as we have discussed this with the GAO, Making this change would require changes to over 70 systems that CMS has. It would also require changes to state Medicaid agency systems, private insurers that deal with us in Part C and D, as well as even potentially on the provider side. So there's quite a bit of burden across the healthcare community to make this change. Again, we're not opposed to it. I think as an agency, we just need to be adequately resourced to be able to take on that challenge.
Just don't hire the same company that did the Obamacare rollout. You can do better. Ms. Schakowsky, first.
I'd like to talk a little bit about fraud in the Medicare Part D program. Dr. Agrawal, CMS released a Medicare Part D proposed rule in January of 2005. What steps did that rule take to reduce fraud in Medicare Part D?
So just to clarify, this is the rule that we finalized now 3 weeks ago, or roughly 3 weeks ago, is that correct?
Yes.
Yeah, I think that rule is going to have really important impact for us in Part D. One thing is it extends our controls and safeguards in Parts A and B to Part D. It will actually require an enrollment of providers in the Medicare program in order to, even if all they do is prescribe in the Part D program. So we'll have much more transparency into who those providers are, and I think importantly, we can keep revoked and excluded providers out of the Part D program so they can no longer prescribe. A second big impact is that it will allow us for the first time to go after abusive prescribing. So this will be not just those prescribers that have actually committed fraud, but allow us to go upstream of the problem and actually be much more preventive to make sure that prescribers that are endangering the safety and health of our beneficiaries, for example, can be taken action against, and we can actually kick them out of the program.
So it's a financial issue, but also a health issue for patients.
Absolutely.
Okay. So I appreciate these steps. Fraud in Part D appears to be a problem that is increasing, and it's important that CMS act quickly to nip this fraud in the bud. But, Mr. Chairman, fraud is not the only problem with Medicare Part D. Waste and abuse is also a problem. In particular, taxpayers and beneficiaries are forced to pay too much for prescription drugs because Medicare Part D plans are not able to negotiate for lower prices. The poster child for high Medicare Part D prices will soon be Sovaldi, which Mr. Waxman was talking about, the hepatitis C drug manufactured by Gilead. The company charges $84,000 for a course of treatment. A recent analysis by researchers from Georgetown University and the Kaiser Family Foundation found that Medicare Part D coverage for Sovaldi alone would increase Medicare drug spending by $6.5 billion, or 8%, in 2015, which is an astounding amount of money for one drug. While Gilead provides substantial discounts on the drug in on this same drug in other countries, and for the VA and the Medicaid program, these discounts are not available to Medicare Part D plans. According to the study's authors, quote, "It is likely to be hard for Part D plans to have an impact on the price in the case of Sovaldi. Part D sponsors have little negotiating power," unquote. But, Mr. Chairman, Sovaldi is not unique. Part D plans are not able to obtain significant discounts on many expensive drugs. So, Mr. Cantrell, the Inspector General has conducted analyses of Part D drug prices and compared prices charged for the same drugs on Medicaid. Can you tell us what those investigations have found?
I can tell you that Part D drug prices are higher. We're paying more in Medicare than we are in Medicaid. And our work has come out of the Office of Evaluation and Inspections and somewhat from the Office of Audit Services. So I'll pass on to Ms. Jarman.
Okay.
One of the things we've looked at are rebates, or the rebates that are actually the Part D drug prices were higher than Medicaid prices because Medicaid received higher rebates. Average rebates for Medicaid drugs were 45% of the cost, while average rebates for Part D drugs were only 19% of costs. And in the compendium of unimplemented recommendations, we actually have several recommendations related to payment policies, looking at lab costs, also differences between Medicare and Medicaid prices for these same services.
And how much would so you're saying that there is an administration proposal that would end the waste and require higher rebates for Part D drugs. Is that right?
I'm not sure if there's a proposal.
Dr. Agrawal?
There's an item in the President's budget that would put Medicare payments on par with the Medicaid rebates.
And how much would that proposal save taxpayers?
I'd have to look back at the OACT estimation. I can get back to you about that.
Okay, well, the number I've heard, and you can confirm it, is about $150 billion would be saved by that one change. And right. I would certainly support that change. Thank you, and I yield back.
Thank you. Now recognize Mr. Olson for 5 minutes.
I thank the chair for having this hearing that's required by our rules. Welcome to all the witnesses. Before I get to my questions, I want to tell you about how Medicare fraud looks like back home in Texas 22, in Houston in particular. These are some stories that have been in local papers. January 24th, 2014, quote, Houston medical device supplier charged with $3.4 million in Medicare fraud, end quote. February 2nd, 2 weeks later, Houston business psychiatrist indicted for $158 million in Medicare fraud. February 29th, Houston physician arrested in healthcare fraud conspiracy. In that case, CMS missed the fact that one person had been tested 1,000 times and built those tests over a 3-year period. April 3rd of 2014, quote, Houston businesswoman convicted of $1.5 million in Medicare fraud. April 24th, 3 weeks later, quote, $70 million alleged healthcare scam busted in Texas. And finally, June 4th of 2014, quote, Houston physician and 4 others indicted for $2.9 million in healthcare fraud in state and federal case. That's 6 months and $200 million in fraud in Houston. And that's what we've known. That's what's been charged, what's been put in the press. We know that's much, much, much worse in Houston and all across America. One area of abuse is billing Medicare for ambulance services that aren't given or provided or needed. And as was mentioned by some of our witnesses, Houston is one of 7 cities in America that have a moratorium on new ambulance services under Medicare. And I believe, Mr. Cantrell, in your testimony, you said that because of the moratorium, Houston's costs have gone down 50% since 2010. Is that correct?
I'm not linking it directly to the moratorium, sir, but okay. They're based on our collective efforts, yes, our enforcement efforts and administrative efforts.
You anticipate my question. So it's not due to the moratorium, maybe due to putting people in jail as opposed to some sort of combination thereof?
Absolutely. We think putting people in jail who commit these crimes is paramount to success in this area.
Can you get us that data, separate the moratorium from actually putting people in jail? Is that possible?
We haven't studied that, the impact of the moratorium. I don't know if Mr. Agrawal
Dr. Agrawal, any possibility of having that information?
Well, we're monitoring the certain measures like utilization and cost as in the moratoria area. I think statistically it's very hard to disaggregate all the work that we're doing from the moratorium alone. In fact, we bring a package of activities between us and the Office of Inspector General that allow us to attack these problems head on. The moratorium is one component. We also have, as you saw the report, the fraud prevention system, enrollment requirements. So I think all of those things together clearly have impact. It's very hard to disaggregate and say that this is the impact of one of those things.
Do you plan to expand the moratorium?
Pardon me?
Do you expand the moratorium with 7 cities, make it go longer?
Well, what we are doing currently, since this is a new authority and the first time that CMS has really implemented it, is that we are studying it to see what impact it does have, making sure that it plays a useful role in our toolbox and that it allows us to, take action against providers that are already in those areas. So until we know the answers to those questions, I think, given that it has a real impact on even potentially legitimate providers, we want to be careful about expanding that authority until we really have a sense of what it does for us.
And I think when that time frame will come out, when you can tell us this is working, we'll expand it, and a year, 2 years, 3 years, 4 years?
Well, we're required by the statute to publish a Federal Register notice every 6 months in order to continue the moratorium or eliminate it or implement new ones. So we will be looking forward to publishing a notice within the next month with that decision.
As soon as you expanded for the 7 cities currently involved in the moratorium, that you'll take it to more cities, 12, 14, 15, 20, 25 cities. If it's working, it seems to be working. Costs have gone down 50% since 2010. Let's go forward.
Yeah, again, I think we're very open to using this authority more. I think we just want to be able to know what its impact is and make sure that we're not negatively impacting legitimate providers or beneficiary access to care. I think that's really paramount for us as an agency.
Thank you, and I have 47 seconds left. Mr. Burgess, do you like my time, or?
Yeah, let me just ask a question on the predictive modeling issue. Prior to the passage of the Affordable Care Act, was there any prohibition on using predictive modeling?
Well, sir, in fact, the predictive modeling became a requirement from the Small Business Jobs Act, which preceded the ACA. There was no prohibition. I think what the Small Business Jobs Act really gave us was the necessary funding to be able to implement this kind of advanced technology.
But predictive modeling has long been known, particularly amongst the credit card agencies. I mean, I don't know how many years they've used this, but it's been some time. It's a reliable way to cut down on fraud. One of the things I've never understood is why CMS has been so slow to embrace it. I'll yield back.
Thank you. I now recognize Mr. Tonko for 5 minutes.
Thank you, Mr. Chair, and welcome to our panelists. Yesterday, the second annual Fraud Prevention System report to Congress was released, which detailed some of the accomplishments of CMS in the fiscal year 2013 to identify bad actors and again, protect Medicare. If we could just visit those report findings for a moment. For starters, Dr. Agrawal, can you just give us a basic description of what the fraud prevention system is and just how it works?
Sure. So the fraud prevention system is an advanced piece of technology. It allows us to perform predictive analytics and other kinds of analytics on claims in Medicare as they are streaming through the system in real time. So the Medicare program sees about 4.5 million claims per day. This allows us to more quickly and specifically identify those claims that need to be evaluated by our investigators and further developed to see if they represent aberrancies or even fraud.
And beyond that, are there other things that it enables your office to do that was not previously available? Are there new opportunities here with that system?
Yeah, I think the system itself is a great piece of technology that allows us to, again, it'd be impossible for a human being to lay eyes on all 4.5 million claims per day. The fact that we have an automated system to pull out those claims and those providers that are really problematic is an amazing step forward for us. In addition to that, it allows us to do certain things as well, like simply deny claims that don't meet payment requirements, which is an ability that the agency had before, but the FPS allows us to do it much more flexibly and quickly.
And what kind of an investment has been made by CMS in the prevention system?
The Small Business Jobs Act came with about $100 million of funding for the fraud prevention system that we have been utilizing in its implementation. As I think we pointed out earlier, we implemented this system on a very rapid time frame and actually exceeded the expectations of the statute by going to a national view as opposed to a regional view, which the statute required initially. We've also shown good progress in the implementation, going from a 3-to-1 ROI to now this year a 5-to-1 ROI that I would point out has actually been certified by the Office of Inspector General.
So, and expanded opportunities there in terms of fiscal impact, do you see it improving even beyond that?
Yes, we have undertaken various measures to increase the value and return of the FPS. Where, for example, applying it against a wider spectrum of program integrity issues, actually using it to identify providers for medical review as one example, being able to implement those automated edits as another example. We do look forward to the value of this program increasing.
Okay, thank you. And Mr. Cantrell, are you familiar with the FPS system and with the results that were released yesterday?
I think Ms. Jarman is the person to answer that question, if you don't mind.
Ms. Jarman?
Yes, it's the audit part of the Office of Investigation, Office of the OIG office that actually did the work and looking at the fraud prevention system the second year. The first year we weren't able to certify the information because of inconsistencies. In the second year we were able to certify both the unadjusted number, the number before adjustments to reflect what actually gets returned to the Medicare Trust Fund. We were able to certify both numbers in the report that went out late yesterday, the larger number being 210 million of unadjusted projected actual and projected savings, and the adjusted number of 54.2, which is a 1.34 to 1 return on investment.
And basically, what is the significance of the certification?
The significance is that the auditors actually looked at supporting documentation, actually did similar to financial audit work to determine the reasonableness of the numbers. So the numbers actually started out as a larger number, and we worked closely with CMS on any concerns we had if we couldn't directly associate these savings to the fraud prevention system, so that we got comfortable with the unadjusted number. Like I said, it started out as a larger number, so it was audit work that was done to make us feel comfortable that we could certify the numbers this year.
Thank you. And earlier, you were quizzed as a panel about the legislative recommendations for further improvements in anti-fraud. Could any of you highlight which of those recommendations would be your top priority?
From a law enforcement perspective, our ability to have asset seizure authority is important to OIG, but also removing the Social Security number from the Medicare beneficiary card is important from an identity theft perspective, preventing identity theft.
Do you all share that same priority?
Yes, I think from our perspective, the removal of the Social Security number from the cards is a very high priority.
Okay, and Dr. Agarwal?
Well, being from the agency that I am, I don't get to make the recommendations, I get to implement them. So, you know, again, we look at all of them. There are others that I think have very high priority because of their impact on our enrollment and screening work. The SSN issue is one that I have looked at specifically. Again, we're open to that recommendation, but need to be resourced appropriately to meet its requirements.
Thank you very much. I yield back.
Thank you. Mr. Tonko, I'd like to get some clarification on something the gentleman asked you. On page Roman numeral 2 of the executive summary of this document you released last night on the report to Congress fraud prevention, you indeed say in this little blue box, the results are a 5-to-1 return on investment, almost double the value of the FPS in the first implementation year. But then when we get into the meat of the text, it also says in here what we found. It says Medicare fee-for-service program and return on investment is only $1.34 for every dollar spent on the FPS. Can you justify for us what that distinction is?
Sure. So number one, let me just say either number, both numbers demonstrates that the fraud prevention system has had a positive ROI. The two numbers, are something that Ms. Jarman alluded to. There is an unadjusted savings number and then an adjusted savings number. We believe in the agency that the unadjusted savings number most directly measures the impact of the fraud prevention system.
And which one of those, the $5 or the $1.34?
The 5-to-1 ROI. And the reason for that is because the FPS is a piece of technology, again, as I pointed out earlier, that points to those claims and those providers that need further investigation. What the adjusted number gives you is the downstream impact of all of a series of work. So not only the outcomes of the investigation, the outcomes of any administrative processes, any recovery processes, and the work of law enforcement referrals. So it reflects dollars returned to the trust fund, but the FPS was not designed to impact the entire downstream process.
Ms. Jarman and Mr. Cantrell, then he's saying your numbers aren't accurate. Is it $1.30? Is $1.34 or is it 5-to-1?
Well, both numbers show again the positive effect of fraud prevention system, but in Office of Inspector General, we feel more comfortable with the adjusted number, which shows the return on investment of 1.34 to 1, because that reflects the actual amount that's expected to be returned to the Medicare Trust Fund. The larger number is the number before adjustments. In some cases, assets are not there to be collected, so the larger number, while it was identified by the Medicare contractors, what actually is going to come in is the adjusted number with the expected return of investment of 1.34 to 1.
Thank you. Appreciate that. Now recognize Mr. Johnson of Ohio for 5 minutes.
Thank you, Mr. Chairman, and I thank the panel for being with us today. You know, one of the ways that has been suggested to fight fraud is increased disclosure of prior actions against providers and suppliers that were enrolling or revalidating their Medicare enrollment. So, Dr. Agarwal, has CMS issued a rule on increasing disclosure of prior actions?
So we have put out, yes, we have actually put out a proposed rule that will allow for more disclosure. But one thing I would point out is, again, disclosure is one aspect of a program integrity approach. If these are really criminals, then they probably won't have much of a problem lying on an application. So we have a lot of other resources at our disposal that include data checks that go beyond anything that somebody puts on an application. And those, I think, data checks have had significant impact on our ability to keep people out of the program or remove them if necessary.
Okay. Mr. Cantrell, Ms. Jarman, in your opinion, would such disclosure help fight fraud, for instance? Would contractors that CMS currently works with, say Medicare Advantage and drug plan sponsors, be better able to identify fraudulent providers up front if they had access to such information?
Well, I think for one thing, if they lied on the application, it would be a means for us to charge them with that actual crime. So we like that attestation by the provider or whoever attesting to the facts on the application, so that we, or in this case, someone might withhold some information to use against them as evidence, if you will, of intent to commit fraud. So I think it would help our efforts on the prosecution and enforcement side.
Okay. Ms. Jarman, any comment?
Yes, and it's in line with what we have also been recommending, that the Part C and Part D contractors report fraud also, so that they can use that information to try to make sure that bad actors are not in the program.
Okay. Ms. King, are Medicare contractors able to share such information with each other? For instance, if a patient or provider is suspected of fraud and they change plans during open enrollment, would the plan a beneficiary is leaving be able to communicate with a plan they are joining about the suspected fraud?
I'm not sure of the answer on that. Let me get back to you.
Can you take that
will.
For the record? And
I
get
don't
back to us?
believe they can, but I'm not positive.
Okay. All right. Well, certainly it would be good if they could, right? Yeah. Okay. Also for Ms. King, Medicare administrative contractors known as MACs. MACs were created about a decade ago. Today they serve as the primary bill payers for Medicare claims. Given that the bulk of Medicare reimbursements are processed by MACs, the bulk of improper payments are also made by MACs. I know GAO is currently wrapping up work examining the work of the MACs. Do you have any early observations on your work that you can share with our committee?
Not from the work that's ongoing, but we did release some work recently that looked at a lot of the requirements. There are different types of contractors that do post-payment review for fee-for-service claims, and we found a lot of variety among the requirements that they're subject to, which is a source of confusion for providers, and we recommended that CMS take steps to align those requirements where it wouldn't hurt program integrity efforts. Okay. So it's not streamlining, but making the requirements more consistent across contractors, we think would be helpful.
Okay. And then a follow-up, Ms. King. GAO has conducted work looking at CMS's management of all program integrity contractors. GAO made several interesting findings, including the fact that CMS did not standardize its requirements for all contractors. One of the consistent findings from GAO's work over the years is that CMS will often sign a contract for a program integrity function, but either fail to measure the right functionality and activities from the contractor or fail to assess progress as the contractor conducts the work. So in what ways do you think the current contracting mechanism that CMS uses, which is subject to the Federal Acquisition Rules, or the FAR, might hinder CMS's flexibility to manage the program well?
Are you referring to the MACs or the program integrity contractors, if I might ask a clarifying question?
I think we're talking about management of all program integrity contractors.
Okay. We did some work recently that evaluated the program integrity contractors that are called ZPICs, and we did find that they had a positive return on their investment, and they are FAR contracts subject to the FAR, and they are cost plus award fee contracts. We made some recommendations to CMS that they could further link the program integrity contracts with their higher goals in the GIPRA Act, so that the goals from the top of the agency flow down through the program integrity contractors.
Okay, so do you think that the current contracting mechanism that CMS uses would hinder their flexibility to manage the program well?
I don't have reason to believe that it does.
Okay. I yield back, Mr. Chairman.
Thank you. Now recognize Mr. Long for 5 minutes.
Thank you, Mr. Chairman, and thank you all for being here today. Ms. King, I want to direct my question towards you. And in my questioning, I would like to focus on the issue of post-payment audits within the Medicare program and the effect they're having on hospitals and small businesses across the state of Missouri. In the Dallas airport last Friday, I ran into a fella that happened to be one of my constituents. We both happened to be flying back to Springfield, and he owns a prosthetics and orthotics company, and if you go to Google and look that up, O&P, it's the evaluation, fabrication, and custom fitting of artificial limbs and orthopedic braces. I'm sure you know that, but custom fitting. He said and told me that Medicare is sitting on $250,000 or better in these rack audits. And so as I go through this little line of questioning that I have here, I want you to keep in mind that fella. It's him and his wife and his son that own a little O&P business in my district. And think about a small businessman that's sitting around waiting for $250,000 and when he might see that money. But as you know, Medicare currently contracts with private vendors, referred to as recovery audit contractors, RACs, to perform these payment audits. These contractors are paid on a contingency fee basis, receiving a share of the improper payments they identify, and they are not penalized if the alleged improper payments are overturned on appeal. So they're going to hold this money and try and prove, because they're going to benefit it, they're going to make money by proving that these were paid when they shouldn't have been paid. But if they're wrong and they hold this guy's money forever and put him out of business, if it's overturned on appeal, there's no penalty for those companies. As a result, the demands by the contractors for medical billing, for medical and billing records have nearly doubled since 2012. Ultimately, this has resulted in an administrative quagmire where the Office of Medicare Hearings and Appeals has suspended the ability for providers to appeal their decisions due to the backlog of almost 357,000 cases, their backlog, so they've suspended it. I recognize that the post-payment audits are an appropriate tool for HHS to employ and have also successfully recovered millions from genuine bad actors in the system. But there's a lot of small business people, just like my constituent, that are out there waiting for this money. Now that it's been suspended, the people that are doing the audits are getting paid for what they find, and even if it's overturned on appeal, there's no penalty for those people. So one question I have is, do you believe that the current structure of the system is designed in such a way that it incentivizes quantity over quality of these audits?
Let me answer your question in several parts. You are correct that the RACs are paid on a contingency fee basis, and they are paid differently from all of the other post-payment review auditors who are paid on a cost basis. And initially, the RACs were not penalized if payments were overturned on appeal, but now they are. So if they lose on appeal, they have to.
Okay.
There's a penalty there.
I had incorrect information on that.
It was initially correct. The volume of audits done by the RACs has increased substantially over the last several years, and they do by far.
Have they doubled since 2012?
Oh, more than that. Well, not since 2012, but probably since 2010 or 2011. And like, for example,
my information says 2012, but okay.
Yeah, well. They've gone up a lot, and
are there 357,000?
Yeah, they are of the
backlog.
Of the $2.3 million of post-pay, 2.3 million post-pay audits in 2012, about 2.1.
Those are audits, not dollars, right?
Audits, yes.
Okay.
2.1 million of them were done by the RACs. You're also correct that there's a huge backlog in appeals, and we have. What do
you do for a small business guy like mine? Him and his wife and his son are trying to make a living in a custom fit part that's not returnable. Nobody else can use that. If they say, "Oh, you shouldn't have got that part. We should not reimburse you for that part." What do you do in that situation? I mean, what can we do?
Well, I think there are a few things. You know, one is that I would be curious to know what the reason is for the payment being declared improper. If it's a documentation error,
Whether the company that's declaring it is going to get compensated if they can prove that it is, whether it is or not. And
but
maybe you can correct me on this too. But excuse me.
Oh, I'm sorry.
It's my understanding that it's 93 and above, maybe 97, 93, 97, somewhere in that range of these 357,000 cases are going to be adjudicated, have been fined in the first place, and the small business guy should have been paid his money. Is that correct? Is it over 90-some% that were proper in the first place and they're holding this money?
I don't know the numbers on that, but
okay. Well, can you find out for me and see if that's accurate? If it's above 90-some% that they say, "Oh yeah, we should have paid you months and months and months ago," maybe after he's out of business.
We have been asked to look at the appeals process and look at the backlog and determine what some of the underlying reasons are, and to figure out whether we have any recommendations for solutions.
Has the GAO ever made any recommendations to more efficiently review claims after payments are made?
We have made some recommendations to improve the consistency of the requirements that the post-payment review audit contractors are subject to. And we have further work underway that's looking at the post-payment review process, and that should be out later this summer.
Okay, thank you. I yield back.
Thank you. Now recognize Ms. Elmers for 5 minutes.
Thank you, Mr. Chairman, and thank you to our panel. I have a number of questions, so I'd really like to get right into my questioning. And I just want to start by saying, you know, just as my colleague, Mr. Long, I also, as we all do, have constituents who are very, very concerned about this issue. They're small business owners, they're medium-sized business owners. They're taking care of our patients. They're taking care of Medicare patients. Now, I just want to outline for you just how ridiculous this process is in relation to the MAC, both RAC and MAC, absolutely ridiculous. Oxygen, CPAP, hospital beds. They outlined for me over a year time, we're talking about 2,600 of those filled. Of those, they have 1,228 audits. That's 46%. Why would any business have to be audited 46%? Dr. Agrawal?
So thank you for the question. I think you highlight a really important and complex topic. So I think what this highlights is, and we try to achieve a balance every day between not being burdensome on providers, making sure that beneficiaries can get access to the services that they need, and yet being fiscal stewards of the trust fund as required by law. And these are areas, just to complete the thought, if you don't mind, DME supplies, orthotics, and prosthetics are areas that the OIG has identified as being very high for improper payment rates.
Okay, and I'm going to stop you right there and
alone.
reclaim my time, because the issue here is they are not getting paid. The product has gone out to the patients, to the family that is taking, the caregivers who are taking care of this patient. This patient has oxygen, this patient has a hospital bed, but they have not been paid. And the timeline, the ridiculous timeline, you know, we're talking about the process of the audit, and then we have the redetermination period, then we have the reconsideration period, and now the administrative law judge, they're coming in and saying, you know what, we can't even take any more new appeals. You know, there's going to be a 2-year waiting just to get a hearing. How can anyone run a business if they're not going to get paid for some of the most basic of, I'm a nurse. These are basic items that our seniors need and use every day. How can these gentlemen that run this business in my district continue to keep their doors open when they're not getting paid? Can you please just tell me how that can be possibly addressed? Now, let me back up also. One of the issues in talking about the fraud, and this is what I see here. There is fraud. We all know that there's fraud and abuse of the system. But you're going after the good guys to make up the dollar difference. You're not addressing the real fraud issues that are there. You're not taking recommendations and applying them. Your own recommendations. Let me ask a question, Dr. Agrawal. As far as the audit system, if the provider is found to, you know, have a low denial rate, why are we not rewarding them? Why are we not saying, look, you're in this category, you know, whether you want to score them, you know, grade them, why are we not rewarding them?
I think that's a great point and idea. In fact, that's something that we got from the provider community, and we're actually implementing in the next round of RAC contracts.
Okay, and when will that round be?
Well, we've been engaged in that procurement for a while now, but the procurement itself has come under protest, so we would have looked forward to actually having it completed by now, but it's currently in that protest process.
And who is protesting it?
Other contractors.
So these folks, my constituents and every other provider, is just left in limbo right now, not getting paid.
Well, I would point out that,
you know, being good actors, you know, playing by the rules, doing everything they can, they're not getting paid, and we're waiting because someone's protesting.
Let me just say that these audits are required by law. The contingency fee structure was set up in statute. This is not typically the way that, you know, most of our other contractors are not paid that way either. They are also post-pay audits, so they did in fact get paid. These are, and just to differentiate sort of improper payments from fraud, these are tools that we actually utilize to lower the improper payment rate, which this committee has identified as a priority. I think we can agree. You know, the areas that the RACs have gone after are areas where there is high cost and high improper payments. The DME supplies that you pointed out are those areas.
How does the RAC auditor, how do they determine, what is it that makes them, that puts a red flag up that they need to go in and audit? What is it?
I think one of the best early indicators is where the improper payments are based on our CERT audits that are also required by law. So the CERT audits pointed out, for example, that the improper payment rate in DME is about 70%.
Okay, but why? Okay, so XYZ provider now has auditors in there. What is it that they did that alerted the RAC auditor to come in?
Oftentimes, it's the area in which they operate. Again, the areas of high improper.
What do you mean the area?
So if they're a DME supplier and 70% of DME payments are improper, then you're obviously going to go.
So every DME provider is just subject to a random audit at any given time?
It is not typically random. It is based on real analytical work to see where improper payments could reside among the specific suppliers. In addition, as I mentioned to you, we are very interested in rewarding those that have low denial rates so that they get audited less frequently.
But we don't know when that'll happen because we're in a protest.
We are you know, we want to get the RACs up and running as quickly as anybody else.
Okay. Thank you, Mr. Chairman, for indulging me. I'm over my time, but I would like to submit for the record and ask unanimous consent. There's a memorandum to OMHA Medicare appellates on the length of time for the administrative law judge hearings on the claims and entitlement appeals.
Thank you. With any objections?
Let me see the document.
Could you send that document over here for a second? Thank you. While that's being looked over, let me just ask a question here that I think is important too. When people get caught for Medicare fraud, is that acceptable? Do they, that's acceptable for the record. When people get caught for Medicare fraud, are they going to jail? Are you finding them? What kind of examples can they be made of? if I can end with a preposition there. So are there criminal penalties that are incurred upon folks who are involved with Medicare fraud? Mr. Cantrell?
They are going to jail more and more. The DOJ reported in strike force cases over 2013, the average length of sentence was 52 months. And that's fairly substantial time in this kind of crime. And that's an average for 2013. Over the last several years, the average has been, since the implementation of strike force, 47 months. So they are going to jail. There are criminal fines. There are criminal forfeitures that are applied. And that is the result, that is the work that results in the recoveries that the government has received.
So can I ask then, of those who are, when you catch someone, the likelihood that they will serve time, they will pay a fine, any idea what those numbers are like?
I don't have that percentage, sir.
That would be important if we get.
I believe that we have some information on that, sir.
Oh, yes, you do, Ms. King? You can get that to the committee? Do you know anything offhand, or can you get that to the
I don't remember off the top, but I can tell you that most of the people, we did some work on 2010 data that came out, I think, in 2012. Most of the people who are investigated for fraud, both criminally and civilly, those actions do not go forward. On the criminal side, only about 15% of the investigations actually result in the action going forward.
What's that percent?
15%.
15%. Only 15% actually go forward to some criminal prosecution? Yes. Are the rest somehow settled, or does that mean you have an 85% chance of getting away with it?
You know, some investigations just do not go forward for a host of reasons.
So, for example, they're not really guilty of fraud, or there's no fraud charges there. Is that what that's my
Well, there are no fraud charges finally brought, or there's
I guess the ones we want to know, if there's a fraud charge, what's the likelihood they're going to see the inside of a prison cell or pay a fine? The rate of success.
I believe we have some high-level data on what the results are, not down to the length of the sentence, but the types of penalties imposed.
We'd like to know. Mr. Gett, you have a quick question?
I just have a follow-up. Mr. Cantrell, the IG identified problems with Medicare C and D plans not reporting data and recommended that the CMS make the reporting mandatory. Is that correct?
That is correct.
And Dr. Agrawal, has CMS done that?
Well, we've taken a number of steps to better align Medicare C, D, and the fee-for-service programs. I talked earlier about the Part D rule that was going to allow us to require provider enrollment in Part D. We're also working on other activities like the Healthcare Fraud Prevention Partnership that actually allows us to exchange data and best practices directly with the private sector, so that we can jointly, work to detect and prevent fraud.
Right. So I'm going to take that answer as a no. You have not made it mandatory. Is that right?
We have currently not yet made it mandatory.
Yeah. Thanks. I think, frankly, Mr. Chairman, I think CMS needs to do that because we know there's a lot of fraud in those Part C and Part D programs. I appreciate the efforts that the agency has made on those other ends, but I think making it mandatory would really help, and I appreciate your indulgence, Mr. Chairman.
Thank you. Mr. Long and Ms. Elmer have each asked for 1 minute, so.
Just a quick follow-up, Dr. Agrawal. On when you were answering Congresswoman Elmer's questions, you said 70%. Are you talking about O&P? Or are you talking about prosthetics, that business? 70% of them are not correct on their billing?
No, what I was identifying was that there's a high improper payment rate for DME, but there's also a high improper payment rate in orthotics and prosthetics.
Okay.
Those are reports that the OIG has also published.
Okay, because if what my constituent is telling me is accurate, in that 93 or 97%, they go ahead and pay eventually, sometime, a couple of years from now. The 70% didn't match up, so I just wanted a clarification on that.
Well, if I could clarify on that point, sir. So of all of the RAC overpayment determinations, only 7% are actually overturned on appeal. That's 7. So of all of the overpayments that the RACs actually get from providers, 7% go on to appeal and at any level of appeal.
But we're talking apples and oranges. We're talking about how many were not improper in the first place is what my question is, not how many were overturned on appeal.
Gotcha, sir.
Thank you. Ms. Elmers, 1 minute.
Thank you, Mr. Chairman. And Dr. Agrawal, I have a question too about what's the period of time a provider has an audit and maybe they haven't been educated. I know that you said that there's an effort to educate. Is there a grace period? Is there a time? What time limit from a change that's made to the time that the auditor goes in are we looking at? if something is flagged to, for an audit?
So if I'm understanding the question, a change in payment policy that would then downstream be enforced.
Yeah, so a change is made. The provider may or may not have had time to, what does CMS consider a reasonable time that that provider should know that a change has occurred?
Sure. So I don't think there's a set time period, this kind of set time period that you're identifying. I will point out that a lot of the audits...
So the change could be made and the next day the auditor can be in the office?
It's typically not like that. The majority of audits that we conduct are around rules and policies that are very well known by the provider community. So the high improper payment rates in DME, for example, are based on documentation requirements that have been around for a while.
Okay, but that's not what I'm hearing from my constituents. My constituents are looking at this situation. They're saying, look, we weren't even aware of that change. Ms. King, would that be something, is that something GAO has recommended, that there be a grace period time or anything like that?
It's not an issue we've looked at. Okay. But you raise an interesting question about education of providers about the documentation requirements and the rules.
One last question, Dr. Agarwal. You did say that one of the things that you are suggesting in the change in the next RAC audit time period is, the idea that those are rewarded. What would you say the percentage if you've got a low denial rate? Throw out a number.
I don't have a specific number. We can actually get that for you based on the contract.
Well, I would like to work with you on that. Thank you so much, and thank you, Mr. Chairman.
Dr. Burgess, you have some concluding questions.
Thank you, Mr. Chairman. Dr. Agarwal, I want to go back for a minute to the article, the Bloomberg article that I referenced that was published on April 28th of this year. Doctors get millions from Medicare after losing their licenses. And this article goes through, sometimes in rather painful detail, of how a doctor would lose their license in one state and then be able to bill Medicare in another state. I realize states have a responsibility here as well, but you, as the payor for Center for Medicare and Medicaid Services, you ultimately have the responsibility about those dollars going out. And even though New Mexico may have erred in not checking a database for someone who lost their license in Ohio, which was the case of one of the doctors that was referenced here, Medicare paid that doctor an additional $660,000 for that doctor to treat patients in New Mexico. The question is, why won't CMS at least do the basics on checking with the National Practitioner Data Bank to see if there is a problem with this doctor's license?
Congressman, it's not a question of will, it's a question of authorities. So loss of licensure is one of the best triggers that we have for removing somebody from the Medicare program. If a provider loses their license in one state, however, and they have a license that's active in another state, we are bound by limits of authority about whether or not we can revoke that person across the entire Medicare program. We can certainly revoke or eliminate any enrollment in the state in which they lost their license. But loss of licensure in one state is not in and of itself a basis for losing enrollment nationally. Now, if there was something underlying the licensure loss...
I've got to stop you there. I find that absolutely incredulous. A guy loses his license, and some of these doctors were charged with fairly serious crimes. And because they had good lawyers, they were able to keep their license in another state. But, I mean, does that at least not trigger some sort of basic curiosity on the part of CMS as to why the doctor lost their license in a given state? What was the crime of which they were accused? And should we keep sending them checks for $660,000?
Of course, and I, again, as a physician, am very frustrated when loss of licensure in one state is not followed by loss of licensure in all states. We do look at those providers, and to investigate or understand what they've done. But again, this comes down to due process. If there is just not an authority that we can, trigger to cause the revocation, then we simply can't do it. I mean, these are the constraints that are placed on us, rightfully by taxpayers to make sure we don't go too far.
I don't want you to go too far, and we've certainly heard from other members, well, some of the problems when you go too far. But should this at the very least, should this not trigger some type of heightened scrutiny on the bills that are coming in from a doctor who has lost their license in another state because of the death of a patient or because they're charged with a serious crime?
It can absolutely be a risk factor. I don't think that that is what's under contention. I think the real issue is whether we can just revoke summarily across the country for loss of licensure in one state, and that is where there are significant restrictions or limitations in our authority.
Do you not have the authority for heightened scrutiny? I mean, here you paid this guy $660,000. Apparently, we weren't scrutinizing very highly.
That may or may not be true. I don't know about the the data in that particular case or what the report was. But we can subject folks to providers to medical review based on a multitude of factors. We can certainly do that in these kinds of cases. But again, providers can, as you know as well as I do, providers can lose their licenses for a variety of reasons. Some of them having nothing to do with healthcare fraud or the extent of our authorities and concern.
Yeah, but it begs the question: should the Medicare system be paying those doctors? I mean, should they even be taking care of Medicare patients? That would, the fundamental question: is there a way that you have of debarring someone who's been accused of or been convicted of a fairly serious allegation and lost their license as a consequence?
So we have a specific revocation authority that we utilize on a consistent basis. The OIG has an exclusion authority. GSA has a debarment authority. We utilize as triggers for our actions the GSA debarment list as well as the OIG exclusion list.
I've got the exclusion list here.
Yes.
I mean, one of the permissive exclusions is license revocation or suspension. One of the mandatory is conviction on 3 or more occasions of mandatory exclusion offenses. I mean, what do you got to do? What do you got to do to lose your ability to bill Medicare and have you guys pay?
Well, I'd have to defer exclusion questions to the OIG since we don't put people on the exclusion list.
The gentleman's time has expired.
Can we let Mr. Cantrell answer the question?
Mr. Cantrell?
We also have a variety of limitations to our exclusions authority. There are situations, often it's the underlying crime or offense that resulted in the loss of license. But the real, I think, vulnerability that we face is we don't have 100% of the data that we would need to implement exclusions in 100% of the cases where we would have the opportunity and the authority. We have a voluntary reporting system to the OIG from the state boards, from other federal agencies. And so that's an area where we know we have incomplete information, but we currently have 57,000 plus entities and individuals who are excluded, and we exclude over 3,000 every year. So there is a lack of complete data that we have access to, but there is still a great number of exclusions that occur.
I just have to ask you, can you not query the National Practitioner Data Bank? Can you?
I believe that we can. There were some restrictions on law enforcement access to the National Practitioner Data Bank. I can't speak to whether that's actually a continuing concern or not.
Can you find out and get me that information, please?
Certainly.
Let me ask in general for this committee if Dr. Agwell, Mr. Cantrell, and Ms. King, to the extent you can. You've heard a number of things there. We recognize also that you are aware that there's more information that would be valuable to you to help pre-screen out people who have some tendency towards crime. The example I gave before, if someone has robbed a bank or is involved with some other fraud that's not Medicare fraud, they could still be involved with this, I think raises all of our questions. And Mr. Cantrell, you just said you don't have a lot of data. If you would please, in a timely manner, get that data back to the committee, as I talked with Ms. DeGette too, and this is something I think this committee would be interested in moving forward on some legislation to assist you in that, rather than just pay and chase moving forward. I want to ask unanimous consent that the members' written opening statements be introduced in the record, and without objection, the documents will be there. Also, in conclusion, thank all the witnesses and members who participated in today's hearing. I remind members, I'm sure many people have some other follow-up questions for you. They have 10 business days to get them to you, and I do ask that you all agree to respond promptly to the questions. So with that, this committee is adjourned. Thank you.